I don't remember from ABIM how much. I mean, they definitely want you to understand the entities of what thrombotic microangiopathies are and how to recognize them, but it's probably more of a practical knowledge and just understanding the depth of the conversation a little bit. But boards will probably ask you one or two general questions about thrombotic. All right. This is a patient of mine. I just saw her about an hour ago. So she was 18 when I met her. She presented with diarrhea and abdominal pain. She had a 12-day history of diarrhea. She was on Cipro for 7 days prior to coming to the hospital, but she continued to have bloody diarrhea and abdominal pain along with fevers. She had no prior exposures or travel history and no medications. She was a daily marijuana smoker, but other than that, she denied any cocaine or other illicit drugs. So, I mean, maybe I'll give you an opportunity. Are there any other relevant historical questions anyone wants to ask me here? Or are you guys okay? Try to make it a little interactive. No? Okay, I'll look out in the chat if I can figure out where it is.
Yeah, no, but I think you guys can unmute yourself and.
Yeah, you can just interrupt me, unmute yourself and interrupt. Okay, so this is what she looked like when she came in. She was normotensive, she was febrile, maybe slightly tachycardic. She had a little bit of pallor and dry mucous membranes. She had a large bruise on her left flank that was noted. Otherwise, her exam was unremarkable. Here's her baseline labs when she came in. So she had some leukocytosis and bicytopenia, a kind of a normocytic anemia and a platelet count of 19,000. She had an acute kidney injury. She had no known prior labs, so we don't know what her baseline creatinine was, but this was her admission creatinine. Electrolytes were pretty stable. She had an indirect bilirubin of 3 and otherwise normal lactate, lipase, liver function, and coag studies. And then her pregnancy test was negative. Any lab questions or things you want information-wise? You guys good? All right, she went on to have a CT of her abdomen, which basically showed inflammatory changes in the colon, sigmoid colon, and then she had a complex adnexal lesion seen in her right adnexa that measured 4.7 centimeters, which was thought to be a cystic lesion, maybe complex cyst in the right adnexa. So additional labs when we saw her, whoops, sorry about that. She had an LDH of 1200, a suppressed haploglobin. She had a normal fibrinogen. She had a reticulocytosis, normal iron studies. Her stool studies were C. diff negative. She had some proteinuria and some bacteria on her UA, as well as some casts that were seen when nephrology saw the patient. She had a borderline B12 level. 302 is kind of borderline, but not significantly low. And then at the time we saw her, her stool culture had been pending. All right, so let's real quick, does anyone want to chime in here? What do you think about these labs? I showed you
with the interns, with the whole like presentation labs, what are you thinking of?
What's that? Sorry, I missed that.
No, I was telling them like we can start with the interns. You can guys jump in if you want me to pick on you, just say whatever you have on mind.
Yeah.
Just thinking hemolysis.
Okay, what makes you think she's hemolyzing?
Elevated LDH with decreasing haptoglobin, and the retic counts.
Yeah. Do you know the sensitivity of a high LDH and low haptoglobin for hemolysis?
Sensitivity wise, I'm not sure. I would, my guess would be they're pretty specific and sensitive for it.
Yeah, they are over 90% for sensitivity and specificity for a low haptoglobin, especially in the absence of known liver disease, right? So yeah, I would completely agree. She clearly has evidence of hemolysis, and that would be supported additionally by the fact that she has an elevated indirect bilirubin, right? So I completely agree with that. Anyone else have any thoughts about pertinent negatives or positives? Not much.
What do you think with the hemolysis as well that she has?
Say that again, sorry.
No, I was like picking on Rohan to see what else he has.
What was the question?
Any other thoughts about her labs?
I mean, platelets are, I can't remember what Troy said, but platelets are low. So
Yeah.
you have to consider that as well. And then the white count is, I mean, it's high, but it's not too high.
Okay.
You've got the bruise.
She has the AKI, which is likely from the hemolysis that's going on, and the schistocytes could be damaging her kidneys. That's my guess. I'm not sure.
Okay, so that you bring up 2 points. One is hemolysis can cause acute kidney injury. Why? Because free bilirubin or free hemoglobin is toxic to the renal tubules, right?
Mm-hmm.
So that's one reason why you can have acute kidney injury and hemolysis. The other reason you mentioned is for thrombotic microangiopathy, right? You mentioned schistocytosis. We don't know if she has thrombotic microangiopathy now, but you're certainly correct that schistocytosis can result in renal failure and liver failure and multi-organ failure from microvascular trauma, right? So we know that if she does have a thrombotic microangiopathy, then certainly that could be a cause. What makes you think she does have a thrombotic microangiopathy or doesn't? I mean, the point of this is not to just put consult hematology, right? The point of this is to think through it as a resident. So what do you guys think? I mean, what are the probability of her having thrombotic microangiopathy or a TMA? She has acute kidney injury. She's got thrombocytopenia, hemolytic anemia, and she presents with symptoms of diarrhea, bloody diarrhea.
It's pretty high, like Shiga-like toxins that are causing all of this.
Yeah, I mean, she meets the textbook discussion points for diarrheal associated HUS, right? So, I mean, I think that those points are valid and should be considered in the differential. So, okay, so let's kind of go through this a little bit. So, an ADAM-TS13 antibody was sent. Her peripheral smear was reviewed. This was her actual peripheral smear that I got for you guys. So what's striking in this smear here?
Akil, you wanna?
What's that?
Akil will answer this question.
Okay.
So you can see schistocytes.
Okay.
That are. Oh, I thought. Mute my computer. Gotcha. Yeah. So you can see some schistocytes. You have some loss of central pallor. The RBCs look fairly small, so it seems like she's hemolyzing fairly rapidly. I think that one, there's some few polychromatic cells as well in there.
What are those?
And no
polychromasia. What do you think these are? That's actually a really nice pickup. What are those cells?
Those are like immature red blood cells that kind of get put out quickly.
Yeah, they're reticulocytes.
Oh.
Right?
Yeah.
So they're enucleated, but they remain there. They are still polychromatic. So they're reticulocytes. Yeah. But that's what, when they're reported polychromasia, you're absolutely right. That's exactly what it looks like. Okay. Okay, so yeah, I completely agree. This is actually pretty striking schistocytosis. I mean, you don't have to be a hematologist to see this. You guys can look at your own smears too. So if you see something like this, this is concerning in the right clinical context for a thrombotic microangiopathy, right? One schistocyte per high power field is not, right? So you know, if you're really thinking about it, this is really quite striking overall. You don't have to look hard to find them. All right. So let's kind of walk through some of these real quick. So obviously thrombotic microangiopathies are a global umbrella term, but there are subcategorizations, which I think you guys know of. The most commonly thought of ones are TTP, obviously HUS and atypical HUS are in the differential. But the important point is not which one of these does the patient have, because that's easily sorted out. The point is how do you make the diagnosis? Remember, all of these are characterized by microangiopathic hemolytic anemia, and all of them have thrombocytopenia. And to some degree, they all have variable neurologic and renal dysfunction, and they all present with fever. So distinguishing between all of them is somewhat nuanced, but again, more of a matter of fine-tuning treatment than an emergent treatment. So just remember for your boards, I mean, if you guys see a peripheral blood smear with schistocytes The picture is consistent with hemolysis and there's thrombocytopenia. This is the prerequisite for having a thrombotic microangiopathy. If you don't have thrombocytopenia, you don't have a thrombotic microangiopathy. If you don't have hemolytic anemia, you also do not have a thrombotic microangiopathy. So consults for anemia and thrombocytopenia and renal dysfunction, concern for TTP are not infrequent for us. And you go and their LDH is 120 and their haptoglobin is 500. This person's not hemolyzing. And by definition, they can't have a thrombotic microangiopathy. So how do you classify these disorders? So there are disorders in which are characterized by ADAMTS13 abnormalities. Those are people who have deficiencies secondary some mutations in the complement cascade, and we'll go through some of those, or antibodies against ADAMTS13. There are disorders of complement regulation, which can be acquired or genetic. There obviously are infection-induced ones, like Shiga toxin or virotoxin-like bacteria producing cells. Also, strep pneumonia is known to produce a thrombotic microangiopathy. There's also rare things like defects in B12 or cobalamin metabolism, as well as quinine-induced thrombotic microangiopathies, which have been reported in the literature. There's other disorders that are associated, but the mechanism in which they produce TMAs is not entirely clear. For example, HIV and cancers have been associated with them, but the mechanism is not entirely clear. Similarly, you can see schistocytes and hemolytic anemia in pregnancy, although fulminant thrombotic microangiopathy in pregnancy is rare, but it has been reported as well. And in antiphospholipid antibody syndrome, you can see this as well. Drugs like cocaine and methamphetamines can also produce this type of picture. So what is the underlying pathogenesis? I mean, generally this starts with microvascular thrombi in certain organs, right? And as someone pointed out, the renal dysfunction because of the schistocytes and the microvascular trauma is what incites the whole problem. Then these thrombi induce shearing of red blood cells. You end up with schistocytic anemia. You then get endothelial damage and activation, which leads to elaboration of von Willebrand multimers, and then enhanced platelet aggregation around those von Willebrand mesh networks, and ultimately microvascular occlusion. And this process is what leads to the microvascular complications and the subsequent end organ damage. So if we look at TTP, I think most of us know that it's a deficiency in ADAMTS13. There are two forms, and this rarely comes up on exams, so just tuck this in your pocket, that there are inherited forms and acquired forms. We all know the acquired form, which is an antibody to ADAMTS13, but the inherited form is called Upshall-Schulman syndrome. And this is when people have a deficiency in ADAMTS13 that is a germline defect, and they do have TTP from the onset. This usually presents in children. So we know that ADAMTS13 is essential for cleaving von Willebrand multimers. So if you have a deficiency, you can't cleave them, and you end up getting, these large complex multimers formed that induce platelet aggregation and thrombi in the microvasculature. But interestingly, there are some people who have ADAMTS13 deficiency, but they never go on to develop the clinical syndrome of TTP. And so that lends you to think that there's other factors that contribute, right? It's not just ADAMTS13 deficiency. So endothelial dysfunction or endothelial damage and activation plays an essential role in actually creating the phenotypic presentation of TTP. So just the deficiency in ADAMTS13 alone is not sufficient. And there's other, I think we talked about this, TTP-like syndromes. One thing you guys should actually tuck away in your mind is calcineurin inhibitors like tacrolimus and sirolimus. They do produce TTP-like syndromes, and you can get schistocytes and hemolytic anemia or TTP with people on calcineurin inhibitors. Similarly with cyclosporin and gemcitabine. Hematology board exams love to test gemcitabine as a cause of TTP, but I have seen questions floating around, Mixap and others, talking about calcineurin inhibitor-induced TTP. So just keep that in your mind, that take a medical history. I recently saw a patient over at Sparrow, I think one of your guys's, who had a liver transplant and was on sirolimus, and we were consulted for thrombocytopenia. And he did not have TTP, but he did have some schistocytes on his peripheral smear, and it's something you have to rule out. So typical HUS, is typically related to diarrheal illnesses, and most commonly is infection with enteropathogenic E. coli. Remember, this produces two exotoxins that are virotoxins. There's virotoxin 1 and virotoxin 2. Virotoxin 2 is more likely to develop HUS, but the pathogenesis behind this is the underlying toxin produced. Whoops, sorry. So remember that the toxin contains B cell receptor binding subunits, and this binds to GB3 on the capillary endothelium. This is what induces the release of von Willebrand factor. That toxin is then internalized into the endothelium and proteolized, and then it binds to the endothelial cells themselves, and it inhibits protein synthesis and induces endothelial cell apoptosis. So this is the mechanism behind which you get endothelial damage and dysfunction with Shiga-like toxin. That's what promotes the TTP and microthrombi. So this ultimately triggers a procoagulant state with platelet activation, tissue factor induction, and then release of von Willebrand factor. Atypical HUS, on the other hand, is a completely different ballgame, right? So this is due to mutations or activation of the alternative complement pathway. So you can have two different things happen. You can have a mutation affecting it, or you can have autoantibodies targeting a protein in the complement pathway, but ultimately it leads to loss or functional impairment of the regulatory proteins of the complement pathway. There are also rare activating mutations that can then activate certain proteins in the pathway as well, but these are the two mechanisms in which atypical HUS forms. And there are hereditary forms as well in which you acquire a abnormality in the complement pathway. These are not common, but they do need to be looked for. So just a review here real quick. So the alternative complement pathway, under normal conditions, you have a constitutive activation or constant check on the pathway through inhibitory proteins that ultimately prevent the complement pathway from overactivation, right? And so that's, this was learned way back in med school. You don't have to learn all of this right now, but just understand that there is an inherent way to inhibit the chronic activation of complement cascade. When you get alternative pathway activation and you generate C5b, C9 lytic complex, that's what leads to the endothelial damage and ultimately the microvascular complications. So activation is typically regulated predominantly by something called factor H and something called membrane-associated cofactor protein. So these two proteins bind to the membrane-bound C3b and promote inactivation. So if you inactivate C3b, then you won't form your membrane attack complex or your lytic complex and continue to activate the alternative complement pathway. So this is your checks and balance system, essentially, to help prevent overactivation of the alternative pathway. So there are numerous mutations along that pathway that can be seen. The most common is factor H mutations. And those can be acquired or germline. And then you can also have autoantibodies, most commonly to factor H, but they can be to other factors in the pathway. There are gene sequencing panels. The only place that runs the gene sequencing panels is Cincinnati Children's Hospital, but there are gene sequencing panels that will sequence the whole complement pathway for you in patients in which you think there is an underlying deficiency. And it is vitally important to obtain those in patients in which you have no other reason to have thrombotic microangiopathy. So this is a very relevant slide for your board exams. So how are you going to distinguish between TTP HUS and atypical HUS? So I'm not going to read you all the words on this slide, but just kind of maybe I can email this to you guys, take this for your board exams and throw it in your memory bank because they like you to distinguish between these things. Just remember, they like to test this problem. Renal failure is way more common in HUS than it is in TTP. So typically they're going to swing the question some way in that form to make you guys understand what they're trying to get at. But they all come with microangiopathy and all come with thrombocytopenia, right? So there's a common factor. The question is, are you going to be able to distinguish the nuances between them? So renal failure is one clue that you guys can get. Obviously, if the person presents with diarrhea, there's a strong clue as well. So take the history, also take the clinical laboratory situation and try to distinguish between these. So I'll leave this slide for you guys, but you don't have to, we don't have to go through it all in general, but.
Dr. Isaac, I have a quick question.
Yeah.
In the atypical HUS, it's saying extrarenal includes cardiac and pulmonary and hepatic. Like, what does that usually, like, how would they present from that standpoint?
So people can present with fulminant hepatic failure from microvascular damage to the liver vasculature, and you can present with altered mental status because of microvascular or ischemic changes in the CNS. Similarly, pulmonary microvascular complications can present with hypoxia as well. So it all has to do with microvascular trauma. Okay. Similar cardiac, right? If you get subendothelial microvascular occlusion, you can present with elevated troponin and non-STEMI-like findings.
Sounds good.
Anything else?
Thank you.
Okay. All right, so let's see what the workup for all these patients should be. So CBC, CMP. So what are you going to see in this? We just went through it. Let's reinforce this.
What do you think, Vinu?
So in CBC, hemoglobin would be low.
Yep.
And elevated liver enzymes possibly, but not as common.
Okay.
And creatinine could be elevated too.
Yep.
Obviously in CBC, thrombocytopenia. So hemoglobin, low hemoglobin, anemia and thrombocytopenia in CBC. Yeah, CMP is LFTs and AKI.
Excellent. Perfect. Okay, let's move on. We talked about LDH and haptoglobin, right?
Yes.
Coag studies, what do you expect? Coag and fibrinogen. Should they have a coagulopathy?
No, they would have normal PT and normal PTT most likely. Am I wrong?
Correct, yeah.
And
No.
and fibrinogen would be elevated. No, fibrinogen would be low. There we go.
Well, actually, you make a very good point. Fibrinogen doesn't necessarily low. So how are you going to distinguish between DIC and TTP?
Sorry. So in TTP, you're basically just forming clots everywhere. What's going on here? So TTP, you're forming clots everywhere and you're hemolyzing the RBCs as they're basically passing the blood vessel. Whereas in D-dimer, you're activating the clotting cascade throughout your body, and that's what's causing the thrombi formation, I think.
So what happens in DIC? You end up getting a consumptive coagulopathy, right?
There's
Right?
consumption of the factors themselves.
Right. So in DIC, you should see a low fibrinogen, a high PT and PTT, right? In TTP or HUS or any thrombotic microangiopathy other than DIC, you should see normal coags and a normal fibrinogen, right? So the boards like you guys to know these nuances. So how they're going to present you a case with a peripheral blood smear, you're going to think you know the answer, and then you're going to look at the answers and say, well, crap, how do I distinguish between all these things that relatively look the same? And it's always helpful to know these small nuanced differences. So fibrinogen and PTT are off in a consumptive pattern, which is DIC, right? This is a consumptive coagulopathy. So you ultimately would have low fibrinogen because it's being consumed and high coagulation studies. And in TTP, where it's predominantly a platelet-driven issue, so this is a von Willebrand platelet-driven problem, you have normal coags, normal fibrinogen, but your thrombi or your microvascular trauma is coming from von Willebrand-related issues. Make sense?
Yes.
Cool. So B12 also can present with a hemolytic picture. And I think people confuse this a lot. Severe B12 deficiency can present with elevated LDH and hemolysis-like labs. So B12 deficiency should be on your differential, and you need to think about B12, but it should be normal in TTP, right? Obviously, drug screens, you need to rule out cocaine and everything we talked about before. HIV and pregnancy obviously always need to be ruled out. And then if you don't have symptoms, could it be secondary from a rheumatologic workup? rheumatologic, obviously these patients shouldn't have antiphospholipid antibody syndrome or something to that like to make you think that there's a secondary cause. Peripheral blood smear we talked about, you should see schistocytosis and evidence of hemolysis. ADAM-TS13, if it's TTP, it should be less than 10%. And if it's HUS, it should be normal. And then stool cultures are vitally important because they can be positive for E. coli or Shiga toxin if you're worried about HUS. So this is kind of how you should approach a patient if you see that you're concerned about TTP. And all of these can help you work your pathway in your mind as to what the most likely diagnosis is. Here is a pathway as to how you work up this. This is actually a very nice schematic from Cincinnati Children's Hospital. So it tells you, I'm not going to walk through the whole thing, but basically tells you, you know, do everything we talked about, rule out other things, and then treat the underlying cause. But if you have no obvious reason, you check ADAM-TS13. If it's low, you have a diagnosis of TTP and you treat accordingly. If it's greater than 10%, you obviously do your stool studies. This is where the problem comes in. If your stool studies are negative, then you're theoretically thinking this is atypical HUS. And then you run into that whole host of complement issues, right? So there can be quantitative or qualitative defects in the complement cascade. And that is when you do all of this genetic sequencing, okay? So back to this case, this patient was recognized to have thrombotic microangiopathy. She was started on plasma exchange. She had 4 days of plasma exchange. Her assay came back at 85%. Plasma exchange was stopped. Her stool culture showed beta hemolytic strep. No Shiga toxin or E. coli was seen. Nephrology saw her, obviously, we talked about her UA was consistent with ATN from her granular casts. They agreed with the diagnosis, and workup for secondary causes were negative. If we take a look at her overall CBC trend, if you look at her platelet count, plasma exchange was initiated here, and her platelet count subsequently recovered quite nicely after plasma exchange was initiated. This is on day 6 of her hospitalization. Her platelet count was approaching 50 and subsequently normalized. So just a summary, because this case is a little bit more complicated, but we'll talk through a little bit more. This patient had microangiopathic hemolytic anemia. She had thrombocytopenia. So clearly she had a concern for an underlying thrombotic microangiopathy. She had renal and liver dysfunction at the time of diagnosis. No other clear causes. High ADAM-TS13 and negative stool cultures for E. coli. What do you think about this high ADAM-TS13?
Because it's according to the scheme that we just saw, it's one of because you have differential diagnosis, right? So if the ADAM is fine, then it's not TTP. You're in the HUS, correct?
Yeah, so you're in the HUS category, right? Her ADAM-TS13 is not less than 10%. So she has hemolytic uremic syndrome. Now the question is, and that fits, right? She had renal dysfunction.
Yeah. And
that was more severe.
Yeah.
Yeah, and it got worse during the hospitalization. I just showed you the initial, lab, but she fits with HUS. The question is it typical or atypical? This is an 18-year-old, right? So you have to think about, she's a young patient, right? She had diarrhea. She had evidence of colitis on her CAT scan when she came in, right? Problem being is her cultures were negative, but she was treated with Cipro for 7 days as an outpatient, right?
Yeah.
So very confusing picture here. You know, what do you do with this patient? So let's kind of go through the management practical points real quick. So it doesn't matter what they have, do plasma exchange, right? You're never wrong if you plasma exchange somebody, right? You're wrong if you say, I don't think it's TTP, and then they go into renal failure and end up on dialysis the rest of their life. So never harm anybody with plasma exchange. So that's the standard of care, particularly for TTP. Untreated TTP has a mortality of over 85%. With plasma exchange, most people do well. So you usually exchange 1 to 1.5 plasma volumes, but you can increase it depending on how they respond to platelet, their platelet count. Their platelet count should rise pretty quickly over 24 to 48 hours and continue to do so. And you continue daily until the platelet count's over 150,000. LDH has normalized and their symptoms have resolved. So what about an atypical HUS? It's unknown. Plasma exchange is still the treatment of choice because this is a diagnosis that typically takes some time to sort out. So you don't wait for stool cultures to come back before you plasma exchange somebody. All right, you should exchange them and then decide based on your workup. Response rates are definitely lower in atypical HUS. Obviously, in Shiga toxin associated diseases, the role of plasma exchange is not clear at all. What about adjunctive therapies? So we just said it's a problem of platelet activation. So does giving antiplatelets help? There's not a real obvious answer to that. There doesn't seem to be a clear benefit in the retrospective data that there is. Does increase the risk of bleeding. What happens when the platelet counts recover? Is there a role for then adding an antiplatelet? There's not a clear role in retrospective literature. So antiplatelets are not thought to be a component of therapy for these patients. Steroids certainly have a benefit in some people who have antibodies towards ADAMTS13 because of the immunosuppressive effects, but there's really no consistent survival benefit in randomized clinical trials. But we do it for people who have ADAMTS13 deficiencies, just to ensure that it's not due to an autoantibody, and we don't want to miss it. So we typically would start them on 1 milligram per kilogram per day. And then in those who don't respond to plasma exchange, rituximab definitely has a role and has been shown to improve outcomes in these patients. Immunosuppression with cyclosporin or vincristine has been tried in multiple trials and certainly has efficacy in these patients, especially those with autoantibodies towards ADAMTS13. So, I mean, the role or the general theme is immunosuppress them if they have antibodies towards ADAMTS13. How you accomplish that, steroids, rituximab, vincristine, cyclosporin, there's no comparative randomized data to guide. So typically people would start with steroids, and if they don't respond, escalate your therapy accordingly. And then supportive care, platelet transfusion is a relative contraindication. Obviously, you don't want to fuel the fire. There's really not clear evidence that outcomes are that detrimental with platelet transfusion. However, there is some decline in clinical status reported in some patients, and it's quite controversial. So generally, we try to avoid platelet transfusions in these patients if we can. Other adjunctive therapies, so the standard of care is Eculizumab. So Eculizumab this is for HUS, for atypical HUS, sorry, approved in 2011. It's an antibody to C5, which is the integral component where your alternative and complement common pathways converge to form the membrane attack complex. The problem with Eculizumab is it's super expensive, but we know delaying initiation of therapy has worse outcomes and more long-term renal failure issues. So you try to give people this therapy as early as possible. And if you're wrong, you just stop it. But you can't, it's not going to harm patients outside if you do it correctly to get the ball rolling. And so we typically err on the side of caution. If we're not sure if this is atypical HUS or not, we typically try to get Eculizumab approved. And we talked about we should initiate it promptly in all thrombotic microangiopathies who don't have severe ADAMTS13 deficiency. These patients all have to be vaccinated against meningococcal infection, and they have to have it at least 2 weeks prior to initiation. So if you're going to do it, you give them your meningococcal vaccine and then try to get the drug approved. You can try Cipro for 2 weeks prophylactically if you want to start before the vaccinations, but typically we try to vaccinate them first and then start it. There's an induction phase of weekly ×4 and a maintenance phase that's given at 5 weeks and then every 2 weeks going forward. Toxicities are minimal, but certainly hypertension can occur and other types of side effects, typically pretty well tolerated though. This is a very controversial topic, is can you stop therapy? We have no idea. The standard of care is lifelong. There has not been a trial at looking at discontinuation, although case reports have been published about successful discontinuation, but there is no data. Obviously, the company doesn't have much interest in creating a trial with an endpoint of stopping therapy. So I don't know that we're ever going to get that data anytime soon, but certainly the standard of care is lifelong.
I have a quick question. What about rebound? Yeah. Is there data about, these people get off the medication, have recurrence, and they end up back? Like, why did they decide it's lifelong?
So the initial trial that was designed didn't have an end in the treatment. So when they did it, when the drug company designed the trial, they designed it in such the way that continuous therapy was the standard. So we never had a subsequent trial comparing continuous therapy to definite therapy. So, for example, stop at 2 years and then see what happens. So relapse rates are not uncommon after stopping eculizumab in case reports. So you have to be a little cautious in who you're going to stop therapy in. But we don't have randomized comparative data. So it was picked that way because that's how the initial trial was designed.
And what about in general, let's say outside atypical HUS, what about HUS and TTP, like recurrence rate? Is it high in the first place? That's why they kind of designed the trial this way?
It's a complex question. The trial is designed that way for many reasons, some of which are internal to the company and economically driven, and some are which are the fact that we don't have an endpoint. So we don't have a biomarker to stop, right? So let me just give you an example. Is normalization of LDH a biomarker to stop?
I guess it's not.
We don't have a biomarker. So part of it is lack of biomarker of what to stop and when. And so does a normal CBC and kidney function for 2 years tell you it's okay to stop?
Yeah, we don't know.
We don't have that answer. And I think that was probably the hard part, is that the discontinuation is so catastrophic if they relapse. And if you don't have a good biomarker to tell you when to stop, it's hard to decide.
Okay.
If you do decide to discontinue, though, there are clear criteria about when you should start therapy again. And it's typically if you have an increase of 25% from your baseline of your parameters. These are the genetics. We talked about them a little bit, but just understand that the vast majority of atypical HUS does not have an identifiable problem. The most common identified issue is a CFH mutation, and then the others are kind of a spattering of other complement proteins. So what happened to this patient? We talked about the fact that her atypical HUS was diagnosed because of the fact her ADAM-TS13 was 85%. And the question was it diarrheal or not, right? And that was a difficult question to answer. So I did end up treating her as atypical. She got meningococcal vaccine. I put her on Cipro prophylaxis and started on eculizumab. So she completed induction eculizumab, and actually she was completely recovered, normal counts and normal renal function, and was discharged from the hospital doing fine. She did have a full genetic panel for atypical HUS at Cincinnati Children's that I sent that was negative for any mutations. So then I was placed in a very odd position because she wanted to get pregnant, and pregnancy is a absolute contraindication while on eculizumab. So I did stop her eculizumab after 2 years of therapy. She has not relapsed yet, and she has a kid that's 18 months old and doing very well. It's still a question in my mind as to this was probably diarrheal associated given her symptoms and CT findings on presentation. Just very hard to prove given her antibiotics before her admission. So. All right. Any thoughts?